Thank you for the introduction, and thank you all for being here today. So what I thought I would start off as, I'm a biomedical research with a background in biopharmaceutical industries as well. I thought I would start off with a personal story to give you my perspective on where life sciences could fit into the treatment of aging and chronic disease. So this is my father-in-law here, Dr. Bill Dahl. He finished UBC medicine. He then became a missionary doctor and went out and was sent to the desert area of Pakistan on the Afghan border, where he basically transformed a mud shack into a 80-bed hospital, very similar to what we're trying to do today in many ways with St. Paul's, but basically transformed this shack that had minimal running water and electricity into a center that now serves thousands of people today and is actually a training center for nurses. But as what happens to all of us, no matter how great you are or what you've accomplished in your life, everybody succumbs to the perils of aging and chronic disease. And unfortunately, in December of last year, Bill was diagnosed with an incurable form of cancer. And in between hospital visits, they stayed with us for that 5 months. And my wife drove him around to the treatments, either out in Chilliwack, Abbotsford, New Westminster, Surrey, and Vancouver. And this picture is actually taken on the day where my wife had it came to a point where nothing more could be done, and he decided he wanted to be at home living with his loved ones and family. So she filled the pool deck up with flowers, and this picture was taken. It was a sunny day, and basically that night he passed away at peace and surrounded by his family. But during this time, it was a really enlightening time for me, because we had always discussed my research since the days I'd been at QLT doing basic biomedical translational research until now. But this time it was different, because he was not only an innovative clinician in his own right, but he was also a patient at the same time. So he could give the perspective of what I could do as a scientist, both from a patient's point of view as well as a clinician. So I'd ask him the question, what is it that I could do as a basic biomedical researcher that could improve your life as a patient from a clinical and a patient standpoint? And from the clinician standpoint, we always had discussions of everything that was going on from a pathophysiological level and understanding the mechanisms and where my science could come in if I could come up with a product. But as his condition started to get more serious, there was also the mental battle that was going on. So this was a guy who was a leader. He had skied up until the age of 78. And the mental battle was that he was now not able to do things that he could do before. So how could science improve his quality of life and patient comfort during those days? And then the third aspect was hope. So from the family and the clinician side, what could research offer for the families and the patients going through this? And it's the hope that their spouses, their children, their grandchildren don't have to suffer the way that he suffered. And what this basically drove home, all these different perspectives, is, if we're going to have a transformative world-class facility, what we really need to do, we can't have the scientists over here doing their thing, the clinicians over here, and the patients over here. We need them interspersed together, where the clinicians are coming to the scientists, presenting their problems where they see the issues are, where the patients see the issues are, planting those seeds in the scientist's head so that when they have these serendipitous discoveries, they're able to recognize them. So luck favors the prepared mind, or chance favors the prepared mind. This is preparing the mind for these discoveries. And likewise, when scientists have these unexpected discoveries, they should be able to come to the clinicians. My experience was an N of 1. But during this time, I wrote 6 grants in various areas, interspersed in these various areas of disease, and resulted in about $2.5 million in grant funding during this time. So this is just interacting with one clinician, getting these ideas, and then going to the experts in the various areas of the hospital and seeing how this can work. Me as a basic scientist, you're a clinician, let's bring our expertise together. And in so doing, working with industry, collecting this IP portfolio to then generate these products which not only treat the patients but bring back a return on investment into the hospital. I'm a big believer that the public care cannot be funded by the government alone, and we obviously cannot privatize, so we need to figure out new mechanisms to bring in income to the hospital. And one way of doing this, Bill was always, we used to joke at how hard it is to get human tissues and samples. He often used to offer his own tissues, but one thing we're not really taking full advantage of in the hospital is we take all these samples to monitor health, diagnose the disease. A pathologist looks at the slide. Then we discard these slides. These slides could be used for drug validation studies. They could be used for bioassays. They could be used for discovery. We could use these working with pharmaceutical industry. In addition to this, we need to expand our biobanks. So Keith will present about the heart and lung biobanks and how that's become a cornerstone of discovery. But we really need to expand this into other areas. So this is where the CACD fits in then. It addresses a government mandate with respect to integrating a world-class health facility, integrating in with the expertise of Nadia and others. If we could get the expertise that they see on a daily basis with hundreds of patients, understanding where the science fits into that, understanding how the big data fits into this, generating new solutions. And we'll hear more about that in the afternoon. As well, we have to remember we have these major research engines at UBC in the background. But what we have is the ability we have animal models of disease ranging in the whole span of aging and chronic disease. We have humanized models. We have access to human tissues that are really hard to come by that we could work with various groups to generate discoveries. And so doing this and moving our products along the line, we can generate this intellectual property portfolio as well, potentially generating spin-off companies and licensing opportunities and ways to return investment back to the hospital to generate and perhaps provide more funding for hospital beds and other things. I think if a research institute is run correctly, it should actually provide revenue back to the hospital, not be a drain on the hospital resources. So moving forward together then, I think the first thing we need is a vision, and I think the vision is to look at so Bill's grandkids and children and family and spouse don't have to go through what he had to go through, and finding out what these solutions are and where we can make a difference. Providing a compelling business plan, and I think we do have a good start to a business plan. And then implementation, and I think we're really on our way with implementation. We could start right away, at least small scale, and build up from our original plan. So what I would like to leave you with then is a Center for Aging and Chronic Disease that addresses the government mandate to focus on aging and chronic disease, integrating world-class science with leading-edge patient care and education, while creating innovative ways to fund the research and healthcare while giving back to the communities. And with that, I will stop there. Thank you.